So we're going to look at key principles really for treating FND, and hopefully give you some practical tips on how to support your patients. I'm conscious that this is a mixed audience, that we're likely to have people from many different healthcare professions watching, so it's not going to be targeted at specific professions, and it might have a bit of physical bias because I'm a physiotherapist, but I'll do my best to make it kind of a summary of some treatment techniques that can be used for all of you. Okay. So I've gone through a fair amount of research when preparing for this presentation, and I think it's quite clear that we're all singing from the same hymn sheet, and often what I found is that there's kind of 5 key principles to treating FND and to managing these patients effectively. First being thorough assessment, and that includes both the subjective and objective assessment, clearly explaining the diagnosis, and then looking at attention and modulating attention, and I'll go into that into more detail shortly. Making sure that whatever we do is graded so that the patients feel comfortable, and that we're not just kind of throwing them in at the deep end. It's important to really build rapport with the patient, and then also to kind of recognise that the patient's going to be living with this for a long time, and whilst we hope for complete resolution of symptoms, it's sensible to educate the patient and kind of empower them to self-manage their condition going forwards in the future. So subjective assessment, it's effectively our way of gaining information about the patient, and I'm sure all of you listening are used to and kind of well practiced in information gathering from our patients. Ironically, it seems to be something that when you speak to patients who have had a diagnosis of FND, we don't seem very good at listening. And what's the point of asking questions if we're not going to listen to the answers? So listening properly to your patients and remembering that often their journey has been a lot longer and more challenging to get to this consultation with yourself than other conditions, because you know it isn't a very well understood condition, and unfortunately the majority of healthcare professions aren't confident in treating FND. So it's really important to kind of not rush your patient and give them time and allow that rapport to be developed in that initial session. I'd really encourage blocking out as long as possible for that first session so that you can really get to the crux of everything, cover everything you need to cover in that subjective assessment on day 1, so that you don't feel like you're breaking up that assessment and kind of interrupting the patient's story. Be as holistic as possible. Richard's talked about how it's a biopsychosocial model, and you know we don't necessarily need to understand those 3 Ps for every patient coming through the door, but I think getting as much information as possible allows us to kind of start building a picture. And often it's not about us understanding the condition and how it's happened, but it really helps to facilitate the patient's understanding of how they've developed the symptoms. Asking purely about stress and trauma is just oversimplistic and often unhelpful, and I think we've all heard stories of patients who've been wrongly assumed to be just dealing with stress, and that's why they've got FND. So I'd really encourage you to use logical and thorough questioning, and this might seem like, you know, teaching you to suck eggs, but it's the basics. Ask them, how are they now? What's their current symptoms? What's their most troubling symptoms? What are their pain levels? And how does their kind of condition vary over a 24-hour period? See if you can understand some of those kind of easing and aggravating factors. Understand the chronicity. When did it start? Is there any kind of trigger that they or you can identify? But don't get kind of really stuck, and don't kind of trying to find one single trigger. As Richard said, it's not always as simple as that. Past medical history can start to kind of give you some indication of those potentially predisposing factors, and they may also identify other functional conditions that Richard had in that chart at the start of the presentation. And then obviously social history will give you some indication of the social side of things, so you can investigate issues that might be contributing to or sustaining their symptoms. and consider all aspects of their life, including home, work, family, etc. And alongside that, from a kind of AHP perspective, we would also look at the home environment and look at equipment and what kind of equipment is in there in the home that might be reinforcing that disability going forwards that we might need to have a look at. And drug history, it's not that you need to understand every drug that the patient comes out with, but I think it's good to have an awareness of the amount of polypharmacy that's out there and to kind of understand the side effects of some of those drugs. So, you know, things like dry mouth or poor digestion could be a result of the drugs as opposed to the FND. So objective assessment, obviously this is your physical examination, and I think one of the most important things to establish is variability and distractibility of the symptoms. Now for me, physical examination starts in the waiting room or when you walk into the bay. It might be when you're treating other patients in the bay, because as soon as you start your consultation with the patient, obviously this is going to increase their attention on their own symptoms. It's going to increase the focus on their condition. And it can be really useful just to kind of step back a little bit and see how a patient moves before they really focus on their FND. Neurological assessment on the bed can be helpful. Obviously there's kind of no situation where the attention on the body is greater than when they're undergoing a neurological assessment from the clinician. So it's a good way of identifying how those impairments kind of weigh up on the bed, but don't let that limit your progression of the assessment. So if somebody presents with a complete paralysis of their lower limbs, if you're a physio, I would still expect you to try and sit them up over the edge of the bed and see how they move from one position to another. Looking at that transition from different postural sets can be really helpful. And this can apply to obviously all professions as well. Looking at how the patient moves into your room, out of your space, how they kind of do things like adjust their glasses, use their mobile phone, things that aren't really focused on you assessing their movement can be helpful to see how variable or distractible the symptoms are. It's really important to kind of remember that this isn't about catching a patient out. This is about seeing how their symptoms vary with attention or distraction. Use functional tasks and activities wherever possible. So rather than focusing on the specifics for a physio, I might not want to focus too much on the strength of a limb. I might want to look about how they can use that limb in weight bearing. For a speech and language therapist, again, it might not be looking at the specific elements of swallow. It might be looking at swallow as a whole or speech. And using kind of novel or less practiced tasks can be helpful. When we develop these abnormal or inefficient movement strategies, it's often quite specifically to do with certain tasks. So not many of us walk backwards in our daily life, so asking somebody to walk backwards rather than forwards, turning, getting on and off the floor and so on. These are all a bit novel and can kind of reduce that kind of practiced element to the movement, making it more automatic. Remove aids wherever possible to explore the effect on symptoms, but don't terrify your patients. You know, if they don't want to have a go without the aids, that can come in a later session. The reason we do it is because obviously adding an aid or adding equipment increases the attention on that symptom, but it also makes it a less automatic process because using an aid involves some cognitive control. Identify any inefficient movement strategies that you can see and explore automatic movement. So within this objective assessment, I'd really encourage you to use the physical signs that I'm going to go through shortly to kind of demonstrate how attention and distraction affects the condition. Video, so wherever possible, use video. You can use the patient's own device if they're happy, and that way they get to take that video away and show their friends and family how, you know, their symptoms are changeable, and that's a really positive thing. And identify the positive signs for FND. So really make sure that you demonstrate everything that you're doing and explain to the patient what you're doing. So we'll have a look at the next slide. I'm not going to go through all of these. Distractibility and variability are the two kind of key signs that many neurologists will look at as a kind of overarching kind of way of thinking about FND. But some of the more specific tests like Hoover sign, abductor sign, and the distractibility or entrainment of tremor can be really helpful, not just for physiotherapists, but for any clinician to use to physically demonstrate how symptoms are changeable. And if a symptom is changeable, it's treatable, hopefully. And it gives some positivity to the session, but it's a really important tool. And I think in the past, it's fair to say that some clinicians may have used these in a secretive manner, a way of catching out the patient, like I've said, but it's not necessarily the case. So I'll just talk through really briefly. I'd encourage you to go and look at videos of this on YouTube, but kind of some signs here are Hoover sign is the top one there, just when this only works in unilateral leg weakness. But if you were asking the patient to extend or use their kind of weak left leg and they can't produce that movement, so they can't produce that glute strength to hold the leg down, the leg's weak, it's floppy, you can move it around. But then when you ask them to focus on lifting up their stronger right leg and you resist that hip flexion, what you will get is contraction of the muscles in the left leg to stabilize the body. And this is something that, again, a lot of physios are probably aware of. I don't know if everybody else is aware of, but if you're producing effort with one half of your body, the rest of your body needs to switch on to stabilize you, otherwise you just fall over. Whenever you take a limb away from the center of your body, the rest of your body has to switch on, excuse me, to make yourself stable. And this is automatic, it's not something that we think about. And this is a really nice way of producing automatic movement. So similarly with the abduction sign, you ask the patient to forcibly abduct their hip out to the side. It's weak and they can't produce that movement. But if you then ask them to produce the movement on their opposite limb and you press in from externally on both hips, you'll feel that that stabilizing force will actually occur in the weaker side. Tremor entrainment, there are some great videos available on the internet I'd really encourage you to look at and embedded within some papers. And this is where if somebody presents with a tremor of a certain speed, if you ask them to do something of a different speed with the other limb, often you'll find that the tremor joins. So if you ask them to tap their head or something, you'll find that they go at the same speed. Or if you ask them to do something completely different with the other limb, there's a moment of distractibility where their tremor will stop whilst they process using the other limb, and then the tremor will continue. And it's that distractibility that doesn't kind of fit with other causes of a tremor. In terms of the dystonia, I'm not going to go into detail. Those are kind of specific common patterns, but normally with a functional dystonia, it tends to be a real fixed pattern. It tends to be a bit harder to treat. And I'd recommend, if you're treating a fixed dystonia, to have a look at Glenn Nielsen's paper from 2014, the Physio Consensus. So explaining the diagnosis, I really think, is one of the best tools in our treatment kit. Using language to validate the diagnosis, use the right language, functional neurological disorder. Validate, FND is common, the symptoms are real, it's not all in your head. Don't reframe the diagnosis as good news, you know, great, it's just FND. It underplays the negative impact on the patient, and it kind of really kind of diminishes the level of disability that the patients experience. Don't describe FND by what's not being found. You know, saying, oh, we've had a look at your scan and we couldn't find a brain tumour is obviously just going to make the patient think, well, you didn't look hard enough. Do use positive signs to demonstrate the role of attention and distraction and the potential for recovery if a symptom is changeable. And do give a brief explanation for the symptoms you've identified if you feel confident to do so. Do focus on the what, don't focus on the why, don't get bogged down in those 3 Ps, but do acknowledge them. And provide written materials and signposter resources for kind of enhanced understanding and support. The blue box there is just kind of a way that it's possible you might want to describe or explain the diagnosis. These physical signs of FND show that your symptoms are changeable and potentially reversible. It can be thought of as a malfunction of the software of the nervous system. The brain's got stuck with a faulty or inefficient movement program, but the hardware of the brain is okay. Treatment will be focused on retraining the brain to use more normal or efficient movement patterns and to learn to identify and manage your symptoms. So I've just popped some helpful analogies and metaphors on there. Some of them we've discussed already. Software versus hardware. A pressure cooker model is a nice way of kind of talking about a build-up of stress or events over time. A more modern way of thinking about that potentially for your younger clients might be thinking about the number of apps open on your phone, the number of windows open on a computer, and how that might lead to kind of poor functioning of the device. B-road versus motorway. I apologise, some of these things just come out of my head during treatment, so I've put them on the presentation, but this is talking about selecting a less efficient motor kind of pathway. So your motorways, your nice direct route, that nice nerve pattern that we've been using to kind of walk all our lives. We walk without thinking. For whatever reason, injury or what have you, we started using a different way of walking, and that was necessary. It was something we had to do, but it's not the most efficient way of doing it. So it's like taking a B road rather than a motorway. Sometimes we get stuck on that B road because it's a nice scenic route, but it's not necessarily the most efficient way of getting from A to B. Sometimes you just need a bit of encouragement or a reminder to get back on that motorway, and that's what we're trying to do. Running around like a headless chicken is just something I kind of use to kind of explain that a lot of movement strategies like walking are automatic, and we don't have to use cortical or voluntary control to produce every part of walking. If you cut off a chicken's head, it will still run around for a bit, but we're not suggesting you do that with your patients. Driving a car, learning a new language, these are all things that take a lot of focus and attention when you're learning them, but become automatic. So that's a nice way to think about neuroplasticity and how the brain is able to change and respond to need, and how sometimes things need lots and lots and lots of practice, but once they're well practiced, they become automatic. We've talked about the needing to use the toilet one, and we've talked a bit about the stage fright and so on, so I won't go into those in more detail. So modulating attention, targeting the mind, these are kind of, I was quite reassured on doing this presentation with Richard, these are common techniques used in psychology, and I think it's something that we have been using in treatment sessions as physios. I'm sure other clinicians use these kind of methods of grounding and relaxation and breathing control to focus a patient during their session. So these are just some suggestions of ones you can use, and have a look on the internet for more detail. Basically what we're doing is we're distracting the brain away from the troubling symptoms or the panic that the patient's feeling when we're kind of challenging them during a session. Thanks, Richard. Looking more physically and targeting the body, exploring physical activity is a really good way of modulating attention, and it can distract the patient from troublesome symptoms. Obviously doing exercise can release endorphins, your happy hormones, it gets you kind of pepped up and you might enjoy the session, and that's a chemical reward for taking part. Start small to build up confidence, so start in sitting, build up to standing. Don't put people on a treadmill on day one just because you think that's the way to go, but make activities fun. Things like skipping, dancing, using a ball, getting on and off the floor, changing the focus of your treatment so that it's not this kind of rehearsed, predictable session can be a really nice way of distracting from symptoms and seeing what more automatic or normal strategies are available to the patient. Using mirrors or video can be a really nice way of externalizing perspective, and there's videos of patients on YouTube where they've discovered this themselves, that they're actually able to move their body easier if they look at their reflection than if they just focus on the internal kind of process of moving their body. It's a really nice kind of way of using that kind of detaching a little bit the visual from the internal. And obviously if you do video, it's great for the patient then to go away and be able to look at that in their own time and make some notes on what they can see, and you can talk through that movement analysis together. Minimising aids and equipment, so again I've talked about it a little bit already, but any kind of aid or equipment increases cognitive load. It increases the work we're asking our patients to do, and it increases attention on that part of the body. It's also generally, accepted that if you're using any kind of aid or piece of equipment, it's going to be a compensatory strategy, and it's rarely efficient, it's rarely automatic. You can't always eliminate them, so make sure that your patient feels safe, and grade any exposure to remove doesn't set them backwards. Grading activity, I think, is fairly common sense. Hopefully, I don't need to go into too much detail, but within treatment, plan the activity increase so that you're not going in at, 100 miles an hour on day one. Use repetition, use practice to build up that confidence in the movement. Give homework, but don't overwhelm. Maybe one small task from each session. Ask the patient to work on overnight or until you see them again. And maybe ask the patient to look at those kind of other factors that are going on in their life, because that's kind of good homework for them. That's something you can't necessarily treat. Avoiding boom bust, so looking at their daily pattern of activity and trying to kind of make those changes gradually in their home environment and their social situation. But kind of don't feel that they need to, don't say, oh, finish your treatment, you're walking, so back to work it is. This is important, that it's a very graded kind of approach to all aspects of that biopsychosocial model. Manage their expectations. I think it's really important to focus on possible recovery and kind of explain that it is possible for some patients, but it's not necessarily, expected for all. This isn't a quick fix, and it does take time to kind of learn new movement strategies, and also be realistic that bad days and relapses might occur. Using goals to kind of instill hope and focus positivity can be really helpful. And also, I think getting the patient involved in that goal setting makes them more invested to achieve. And that's, this isn't specific to FND, this is for all patients, isn't it? Focus on activities and participation for your goal setting where possible, rather than say, I'm going to increase your leg strength from 3 to 5, because that's just not consistent with this FND picture. And probably one of the most important factors, I think, is education and empowering that self-management going forward. We want to create expert patients. It's not new to FND. This is something I was doing, 15 years ago for MS patients and Parkinson's patients. This is important to educate anybody with a chronic illness on how to manage their symptoms. Empower your patients, give them a workbook, get them to write down what they're doing, get them to kind of make notes of what's working for them and what strategies can they use. Involve friends and family to reinforce the treatment and management strategies outside of treatment. And encourage cautious self-monitoring. We want the patient to kind of be aware of some of those triggers, but we don't want to really drill down on that attention and focus every day. It's good, like I said, to have those self-management strategies and have a plan for when things might go wrong, but also really helpful to keep the lines of contact and support open in the future. I think people are often worried that if they discharge a patient but say, I'm here if you need me, that you're going to get daily emails. And every patient I've treated as part of the FND study, certainly I've said that to, and I've not had any contact from any of them, but when I've reached out, they've been doing well. So just briefly, I wanted to just kind of touch on, because we did a kind of learning needs analysis, and we found that a lot of therapists across Greater Manchester were quite keen to discuss what do I do if a patient doesn't get better? And I think, it's just worth remembering that for any condition, you can only provide the best treatment that you're able to provide. Do your best. If a patient doesn't respond to what you can offer, then that might not be the right patient for your treatment. It might not be the right treatment for that patient. It might be the wrong time. It's okay to discharge and review at a later date and encourage the patient to explore other therapies. Some patients with more complex presentations might need an inpatient multidisciplinary stay. In that case, I'd encourage you to refer back to the neurologist. And obviously, psychiatric disorders alongside FND can make the patients more challenging to treat and add complexity, and that might require referral to specialist mental health services. Finally, if somebody discloses kind of significant trauma and you don't feel able to manage that, I'd kind of just reassure you and say, do what comes naturally, really. Listen, acknowledge that trauma and be sympathetic, but it's not your job to treat the trauma or try and resolve the trauma in any way. Refer on and signpost to appropriate support services and treatment, but ultimately I encourage you to kind of listen, acknowledge, support, feel the responsibility to treat. Okay. So I haven't really got time to go through profession-specific approaches to managing FND. We have added some summaries, which we can make these slides available for you to look at after the presentation. I think what was really reassuring is from looking at these papers, we are all absolutely singing from the same hymn sheet. We are all providing the same kind of treatments. There's the same principles governing what we are doing, certainly as allied health professionals. Physio, OT, speech and language therapy, there's very, very common ground between our treatments. But that's not to say, you know, there are incredibly detailed, brilliant resource papers out there for you to read, and I'd really encourage you to check the references that we'll provide and go and have a read of the specific paper that meets your profession. I am not a speech and language therapist. I did not understand everything that was in that paper, but it's incredibly detailed. And I know, personally speaking, from a physio perspective, Glenn Nielsen's paper gives ideas about language you can use, specific techniques you can try to look at movement strategies, different presentations, what to do in different situations. There's so much useful information out there. I'd really encourage you to go and have a look at those papers. Okay.
So I think we're more or less out of time, but just to wrap up, thank you, Anna. I think if there's we'd just like to end on some kind of key take-home messages, and particularly that the FND is a common condition. It can be hugely disabling. It's real to patients. It's a genuine disorder and should be diagnosed using positive signs rather than just through exclusion. It's a complex condition. It results from a combination of biopsychosocial factors, and appropriate delivery and explanation of the diagnosis is key, and we all have a role to play in reinforcing that diagnosis. We've talked through some of the common themes to treatment, and as Anna said, there are excellent resources out there that can be used to enhance your knowledge, and we will share information about that. Research is obviously ongoing into the condition, but I think, as we said at the start of the presentation, I think providing compassion and support for our patients should be the bedrock of what we do, and we're grateful for your efforts in that regard. Thank you.
Thank you.
Thank you very much to our presenters today, Anna and Richard, and thank you everybody for joining. We do have a really good question from Sam today, and he has asked if there's a difference in which treatment strategies you would use when treating functional seizures versus continuous functional movements. And that's to, would you like to answer, Anna, or?
Yeah, absolutely. If it's the Sam that I think it is, it's a lady, but I might be wrong. I personally, as a physio, I would only attempt to treat things that physios would treat, which would be the movement disorder element of the presentation. I think that a lot of the education, the explanation of the diagnosis, and exploring some of the triggers and the predisposing factors can have an incredibly good effect on functional seizures. And often when treating one aspect of the condition, you see a resolution or at least an improvement in other symptoms that are presenting at the same time. But I wouldn't necessarily set out to treat seizures as part of my treatment. Saying that, if you are treating a patient who has mixed presentation such as that, it's sensible to at least understand as a physio, OT, speech therapist, how to manage those functional seizures in practice, how best to respond, and it's important for the team around that patient to know the best way to respond. I think it's really important that they're involved with psychology, basically, and I'd be looking to refer to psychology to manage the seizure aspect. Now, they don't have to be running concurrently those treatments. I think I've absolutely treated patients from a movement disorder perspective, and seizures have happened during treatments, and we've allowed them to happen, and we've continued the physical treatment. And that's happened because the patient's not been able to access psychology at that time. And then I've referred on to psychology following my treatment if the patient needed that. With some patients, the seizures do resolve. Richard, do you want to add anything? I assume you have it the other way around, probably.
Yeah, I was just going to say it's really reassuring to hear you say that. That's exactly what I would have said as well. That I think the continuous functional movement presentations are very much the province of physio, and I wouldn't consider myself expert in that at all. I think Anna and her colleagues are the people to work on that. The functional seizure presentations, I think, are a kind of bread and butter for psychology, and often there the work is, I mean, obviously in the context of an individual formulation to try and understand what might be driving the seizures, but typically we would be doing work around identifying early warning signs and triggers for the seizures, so that we can enable the person to try and predict when they're likely to have one, and then apply techniques to try and prevent an attack from happening before it does. And that very much depends on the individual and the nature of their attack. So if it's due to hyperarousal, then we might be looking to use strategies to bring the person's arousal down. Whereas if it's hypoarousal, then we might be using strategies to try and increase their arousal and bring them into a more of an acceptable window of emotional tolerance. Often it's in the context of problems regulating emotion, and sometimes also in the context of a trauma presentation as well. And there, the kind of the seizure specific work is essential, but then there's broader work around what might be driving the seizures in the first place. But I do think that the approaches are quite different for seizure presentations and motor presentations.
Thank you, Richard. We've got another question. I'm not sure. I think maybe Anna to pose this to. Are there any relevant resources for dietitians?
It depends what aspect you're trying to treat. I think there are papers out there that are aimed more multidisciplinary, and they describe interventions in rehab settings where the approach is multidisciplinary. A book has been published today, so I haven't read it, but it's about interdisciplinary management of FND. So that may well be a really useful resource. I assume it will be. But I think looking at the speech and language papers might be useful. The one that I've quoted, and we will send out kind of details and links to those papers after the event. I think that would be useful, certainly, because it's difficult, isn't it? It depends what aspect of FND is affecting the nutritional intake, but usually it's linked to some kind of swallow problem. Otherwise, I'd say it might be more of a psychological issue if it was more around the actual, eating and drinking aspect, that you'd need to speak to psychology potentially. Apologies, it's definitely not my area of expertise.
Yeah, I'd agree with what Anna said. I think that's exactly how I would approach it too.
Thank you both. We have one other question from Laura. She's wondering how widespread the knowledge is of FND amongst physiotherapists, and if referred as GP2 physios for movement therapy, would this be generally well accepted? I'm guessing to Anna this one.
I would say I'm finishing for maternity leave in a week, and I've had about 6 requests for training from physiotherapists this week, because I think there's panic that I'm leaving the trust, and I think it's a good indication that probably people aren't confident to treat this condition. It's difficult across Greater Manchester. We've got about 50% of the teams accept the neuro-specific community physio teams accept FND as a kind of diagnosis, and 50% don't. So then you have a real variation in the skill level of physiotherapists treating these patients. You also have for me, I think they're best treated by neurophysio, because I think having a good understanding of neuroplasticity and normal movement that comes with a lot of the neuro kind of teaching, I think that's really important when treating these patients, and having the confidence to really push people and look at all of those kind of more kind of normal movement responses, automatic responses to balance and so on. I think any physio can treat these patients successfully. Any OT, any speech therapist can, if they've got an interest in it. Most of my learning has been from reading papers and research and experience. So yeah, I think generally, unfortunately awareness is out there, but understanding is really, really poor. And I think I could probably say that for most healthcare professionals across the board. But I think things are improving. Absolutely, things are improving. And, we had close to 300 people sign up for this presentation today, which is really kind of reassuring that people have an interest in this condition.
Thank you, Anna. One last question I think we've got. It's how do you work with neurologists, physical health doctors in the hospitals to prevent readmission to hospital, which can lead to harm from over-investigation?
Tricky one to answer. I think it's difficult because I'm not in A&E, I'm usually in an acute neurology unit. We don't have a specialist FND service, strictly speaking. I'm about to go on maternity leave, and I think my personal interest in FND meant that we had a number of patients admitted with FND that I treated, but the future of the service, I'm not sure what where we stand. And I think one of the issues that's common is that these patients will present to A&E, and because the management in A&E isn't always as good as it could be, I think I have numerous examples where patients haven't been given their diagnosis clearly. It's not been documented in discharge summaries. Patients haven't been coded appropriately. I think a lot of these patients are slipping through the net, and unfortunately that's probably contributing to that constant coming back to A&E, because the patient isn't being managed appropriately at that very initial start of their journey. I think what we all probably have a responsibility to do is improve our awareness of the condition and our skill in delivering a diagnosis, and hopefully that will improve things going forwards. I hope I've answered your question. It kind of disappeared, and I don't know whether I've fully answered it there. Sorry.
Could I come in there at that point as well? Sorry, Fahim. I mean, I absolutely agree with what you're saying there, Anna, and I think admission is difficult to prevent for the reasons you've said. I do think we've got a role, healthcare providers have got a role in communicating with doctors and other professionals involved in someone's care, because I think that there can be inappropriate investigation and inappropriate treatment. And I've seen more than one case where someone's been given a very clear diagnosis of FND, very good treatment plan in a specialist setting, and then they've gone back to a provincial hospital, and the diagnosis has been undermined by a neurologist who doesn't believe in FND. And I think we have a role to educate professionals and to communicate with them to ensure they're aware of the condition and are treating it appropriately, because I think one of the big problems with the condition is iatrogenesis and the damage caused by inappropriate treatment. So I don't know if that sort of adds to answers your question, but I think it's an important part of the issue.
Thank you, Richard. Thank you both. I think that's it for the questions. I think we've answered all the questions. And thank you both for your time and for the presentation. It was really, really informative. Thank you everybody else for joining today. But for today, I think we can end it here, and we'll see you again in a new webinar pretty soon. Thank you.
Thanks everyone.
Thank you.